Great, welcome everybody. Armando, should we just put up the first slide and show the first slide there? And we do want those of you who have logged in to know that we are recording this, and we ask that others not record this. We will be sending the recording and the slides, and we will also be posting our slides on our website. This is actually an informational webinar, so we are not going to be we're not going to have Q&A at the end just because we have so much to cover, but we do invite active chat, and we will absolutely look at all the questions in chat, may reach back out to you. But we want to welcome you to Project Pivot. This is our 1 year, I guess, anniversary. We launched a year ago and we concluded this, and we are this phase of Project Pivot. We are about improving patient safety, diagnostic excellence, and reducing biases in care by learning from patients and families, by learning through the measures and the outcomes and the experience that many people collect. A big thanks to our funders, the Gordon Betty Moore Foundation, the John A. Hartford Foundation, the Jewish Healthcare Foundation, the Patient-Centered Outcomes Research, and AARP. Next slide, please. So a big thanks to the commitment and energy of all of our team. We've grown exponentially over the year. And besides the leadership team, we have created a data analysis team who's been instrumental to the group, our priority population team that I'm not going to read all their names, but get to know them, our research team, and then our healthcare system leader team. And you're going to hear from a lot of these people throughout the webinar, but their commitment has been just amazing and has been, a big part of the success of Project Pivot. Next slide. So what Project Pivot is doing is we are addressing a problem. And the problem is that medical error is the third leading cause of death in the United States. So this is not news to most of us. And that diagnostic errors harm, either people die or permanently disabled up to 800,000 Americans a year from diagnostic errors, from missed, wrong, and delayed diagnoses. So this is a problem. Our nation is aware of this. Medical and diagnostic errors disproportionately impact those most vulnerable, in part because of bias in care and having misconceptions about certain populations. We know that the current measures to understand the problem are inadequate. And to further show that problem, that the OIG, the Office of Inspector General, came out with a report this year sharing that hospitals did not capture half of the patient harm events. So this actually limits the opportunity to improve safety diagnosis and biases in care. So this is setting the stage. This is the problem. Let's go to the next slide. And so because of this problem, there is a national call from our leaders in healthcare to learn directly from the patient community, patients and families, to improve experiences and outcomes related to safety, diagnosis, and discrimination and bias. And just to quickly illustrate, the CMS structural measure that is very prominent, it calls for mechanisms to learn from patients, including their experience and their complaints. CDC's core elements on diagnostic safety directly calls for the inclusion of questions in experience surveys around diagnostic concerns. Leapfrog Group, calls for senior administrators to ensure that there are mechanisms in place for patients to report diagnostic concerns. The IHI Safer Diagnostic Safety Diagnostic Checklist also calls for seeking patient and family feedback around diagnoses. And PCORI and other research entities actually are basing their research on the outcomes and experience that matter to us. So the message is, the nation needs to hear and learn from us. Next slide. But it's curious that, although our nation is calling for healthcare systems and researchers to learn from the patient community, most of the current tools and surveys used in research and quality assessment do not directly ask patients about their experiences or outcomes around patient safety, diagnoses, or bias in care, or importantly, how it impacts them and their families. Let's go to the next slide. So, so our long-term goal at Project Pivot is to integrate new survey questionnaire items into national, organizational, and research measures. We all know age caps. Um, Many of you are familiar with patient-reported experience measures and patient-reported outcome measures. These are basically surveys that capture information from us. So we want to integrate new questions into these measurement tools to measure safety, diagnosis, and biases in care. But these are questions that are prioritized by patients. Next slide. So we have some key principles underlying Project Pivot that are really quite different. First, we are patient and family centered, meaning we focus on the outcomes experience that matter to patients and families. And it is led by people with lived experience. We are all about building community partnerships and inclusion with all stakeholders. So, although we are really patient driven, we see the value of including all stakeholders so that when we at the end of the project, our outputs are more implementable because we've all worked together throughout this past year. We focus on vulnerable populations. Project Pivot focuses on birthing people of color, older adults, and people with disabilities. And maybe most importantly, we really focused on creative engagement methods and rigorous qualitative methodologies. In that we really move beyond traditional approaches to develop patient-reported experience and outcome measures. And we embrace, to begin with, a blue sky approach with no constraints to identifying de novo what mattered to patients. So we didn't start with a literature search. We actually ended with comparing what the patients came out with to what was, the validated tools that are already out there. Next slide.
So,
Okay,
thank you, Sue. Hi, everyone. So, I'm just going to walk you through what Project Vivid did. So, the first step is to collect data. We conducted 9 different events ranging from in-person meetings, virtual gatherings, conferences, storytelling sessions, and so on in order to collect data. And through these 9 events, we had 349 participants, ranging from 100 patients, 149 professional stakeholders, and 100 participants that didn't have primary affiliation. And at the end of all these events and all these participants, we had 2,457 individual responses. Next slide, please. So I'm going to walk you through a snapshot about the methodology that we conducted to collect, analyze, and interpret data through Project Pivot, starting from September 2024 till August of this year. So like I said, we collected a lot of data and we cleaned the data, we analyzed it, and then the subsequent step was to do the coding. And the qualitative coding is a kind of similar to kind of grouping and categorizing all the responses that we have under themes, in which the theme and the responses underneath it have similar traits. For example, it addressed the similar issues that the patients are reporting, or addresses similar parts of the process in the healthcare delivery. And we use a very famous software called NVivo. And we did this over several stages. In some, we used AI coding that we further refined to further kind of represent the responses that we have. And we did also a lot of manual coding to present and kind of have all the responses that we have underneath these themes. After we're done with the in vivo coding, we did kind of a second coding step. And in this coding step, we did it to further refine or reduce the number of responses that we have to a reasonable number that we can work through in the subsequent steps. We did this over several rounds of coding that we did together with the team members. And through this coding, we went through every response and we asked ourselves 3 questions. The first one is whether or not this question address an inpatient setting in the hospital. The second question is whether or not it's directly related to patient safety. After that, we asked ourselves, is the question is more comprehensible, so it represents the needs of a larger population, or is it more unique, so it emphasizes the special needs of certain populations? And if the answer is yes to any of these questions, then we would take this response to the further filtering stages that we did. And we also made sure that we did this as a collaborative effort between all the team members to reduce our own biases and rely only on evidence and on the data that we are analyzing. And at the end of all these steps, we winded up with 48 themed responses. And what I mean by themed responses is an overarching questions that came across all these categories that you see: patient safety, diagnostic safety, discrimination and bias, and transparency. And also, we ended up with 86 population-specific responses across the three priority populations that we have: birthing people of color, older adults, and people with disability. Next slide, please. So in this slide, you can see different themes that, or buckets, like Sue likes to call them, that kind of represent the 48 overarching questions that I just mentioned. And we arranged and color coded these themes according to the stage of occurrence. So the first box, or the first theme, is the harm: the physical, emotional, psychological, and financial harm to patients and families and how it impacted them. The following set of themes in the blue color kind of represent what happened. So we had questions related to the patient safety events. We have questions related to being dismissed. A lot of questions related to bias in care. And later on in the presentation, when you see the actual questions, you will see how it fits into these different buckets. And then in green, we had themes that represent questions related to how harm event or near miss was managed by the healthcare system. So we had themes related if the patients and family members were informed on how to report harm events. We also had themes related to if the healthcare institution attempted to cover up medical errors. At the end, we had the questions related to a theme that expressed how all of that affected the perceptions of safety and trustworthiness for the patients and family members. Next slide, please. So,
Great. And so thank you, Esan. And so, with these 48 well thought out questions, we then had to ask ourselves, what do we do with these? And so for the next step, we asked ourselves, which of these 48 patient-reported outcome and patient-reported experience survey questions would be most implementable? And maybe connect the dots between what patients want to report, or what we want to be asked, and what our nation's leaders are calling for. So we wanted to really look at the environment of our nation and connect the dots between what we want to report and what our nation's leaders are really calling for. Next slide. So we actually put through our 48 questions. We mapped the 48 patient-generated questions to the expectations and the best practices in national patient safety and diagnostic safety initiatives. And you can see the agencies and organizations on the right. So we carefully looked at the patient questions and said, does this really provide feedback and provide insights into the degree to which these national initiatives are really being meaningfully implemented in practice? So we went through quite a mapping exercise, and we came out with 18 pivot questions that could potentially serve as a feedback mechanism. If our nation's asking for certain actions to be taking place, why not ask the patients if indeed it's taking place? Next slide, please.
all right, thanks, Sue. So after that, we took those 18 questions and we provided them to two groups. One group represented patients and family members. The other groups were representing the health system professionals. We asked them to prioritize those 18 questions. So we did this prioritization over two stages. The first stage was where we called it like a level up system. We laid out all the questions in kind of level 0, and we asked them to move the questions upward to level 1 or 2 according to how much they resonate with the questions, like you see here in this picture. The second stage is that we gave each participant 3 votes, and we asked them to allocate those votes to whatever questions they like. At the end, we collected all those votes and we analyzed them, and the results were very interesting. Armando, next slide, please. So this slide represents the kind of the outcome and the themes of the shared priorities that were identified by both groups. So the first row, we have the number one priority that was identified by both patient family members and healthcare professionals, and it was harm from care and how it impacted patients and family members and the response to that. And Sue is gonna dig much deeper into this in the upcoming slides. The second row represent those priorities that were similarly ranked between both patient family members and healthcare professionals, and it include reporting safety, being dismissed, family members or caregiver being there as advocate, biasing care, and understandable medical record information. And Vonda is going to talk to us about the exact questions within each theme. The last row represent those questions that were ranked or prioritized by both groups, but they were ranked differently. And it included discharge and everything related to discharge information and education, test results in a timely and understandable manner, escalation of care, and seeking a second opinion. What was really actually very interesting is that those kind of questions that were unique to one group and not the other. So, for example, bending test results at discharge were prioritized by patient and family members, but not health professionals. What was actually unique to health professionals was perception of safety, medical records accuracy, and the means to correct them. And also, Vonda is going to talk to us about the exact wording of the questions that were mentioned in that day. Next slide, please.
So as I mentioned, the number one question that patients want to be asked or they want to answer was, did you or your family member experience unexpected harm? This is a big void in the current questions that are being asked of us when we receive care. So it was from, harm from care or treatment you received. This could be diagnostic error, it could be discrimination bias. And if so, what happened? And then how did it impact you and your family, and how was the incident managed? Now, this rose to the top over, when we actually launched the project, but we wanted to continue doing the project over the year to really validate this. And so this was the number one. So I want to dig into some of the outcomes that the patients really want to share. And we're going to do a high level big gap analysis and share where did we find measures and where didn't we. Now, I want to thank all of you who did submit patient reported outcome and patient reported experience measures that are validated. And we're still going through the process of mapping them. So we can go to the next slide. The first, of the patients, really want to report that they've been harmed. Death, long-term disability. I'm not going to read all these, but just take a look at all these boxes and these buckets. And this is what patients experience, and this is what they want to report. Now, the blue circles you see coming up is we've done a pretty high level gap analysis. We've invited people to submit prems and proms. We did a literature search at the beginning of the project, and we also use AI to uncover measures that already exist, measures that are kind of related, and measures that are missing that we could find. So the blue circles indicate that we could not find any measures really. Now, of course, patients can't report their own death, but patients' family members want to have the opportunity to report when there is a death. Days alive were shortened, unnecessary treatments, near death. These near-death experiences were simply not capturing years lost from living a healthy, productive life. So there's others. We don't have time to dig into the actual gaps, but this is the indication that there's opportunity to create new measures. Next. The other outcomes and impacts patients want to report are the psychological and emotional harm. You can see here, again, I'm not going to read it all, but I'm going to go ahead and put the red. So the intergenerational harm, we heard from many of our patients, that it not only affects the immediate patient or family, but the kids and the generations, that there is this long-term harm. The disengagement with healthcare system, we could not find measures related to that. The loss of trust and perception of trustworthiness in the healthcare system, and the constant feeling of being unsafe. And so, there are many opportunities to develop these types of outcome measures. And go to the next. This next, the financial harms. You can go ahead, Armando, but we found this is where there is the greatest gaps. We found one measure that's related to cancer. It's called the cost measure, that does measure some costs. But as you can see, all of these other areas, I mean, patients, this is what patients live, patients and families, and really there's no mechanism to understand the financial impact. Um, you can keep clicking, Armando, the financial impact of diagnostic and patient safety events. And we think it's extraordinarily important. And you can see on the right here, there was an article that just came out maybe 3 weeks ago. Tejal Gandhi and Carol Hemelgarn, one of our board chair at Patients for Patient Safety, they wrote an article that identifies that we really need to create better measurement strategies for harm regarding financial harms. Next slide. Okay, Vanda, I think you're going
So
to.
Sue has covered the very top question on that list. I'm going to cover the other two rows. Those were shared priority questions among patients and family members, as well as healthcare professionals. And then I'm going to cover a couple of questions that were unique to patients and family members and healthcare professionals. And then we're going to hear from some of the leaders who ran the priority population questions. So these are the questions right here. There are 5 of them that were shared priorities among those two groups, and they were also similarly prioritized. Underneath that very first question, which Sue just addressed around wanting to report harm. The first is, were you informed how to report a patient safety or diagnostic concern or experiences with biases in your care? And then during hospitalization, were you or your family members' concerns dismissed? This aligns with the IHI report, I'm sorry, with the ECRI report that came out earlier this year. Were you encouraged to have a family member or caregiver to act as an advocate during your hospital stay to coordinate the post-discharge plan and care? During your hospitalization, did you or your family member feel that you were treated differently due to personal characteristics, bias? And then lastly, on this list of similarly prioritized questions, was the information contained in your medical records, notes, test results, etc., provided to you in a way that you could understand? Sue, I think you might have a couple of comments before we go to the next slide.
Thanks, Vonda. I do want to share the number one question that patients want to be asked about harm. There are validated measures globally that ask very similar questions. So Australia, in their national patient reported experience measures, they do directly ask if patients have. Now they use a little different language, but there are validated tools. Australia, the United Kingdom, many of the OECD countries. Now that stands for the Organization of Economic Cooperation and Development. So other countries are asking directly to patients after their hospitalization if they experience some type of patient safety incidents or if they experience harm. We did not find any specific, however, to diagnoses. The other questions here that Vonda is sharing, there are some validated tools that have very similar questions to the top 4. However, this last one, the information contained in your medical records, we were unable to find anything similar to that. So there is an opportunity to develop measures around this. Go ahead, Fonda, on the next slide.
Great. Thanks, Armando. If you want to go ahead and go to the shared priorities that were ranked differently. So again, here, this list of three is, again, patients and family members, as well as healthcare professionals, all agree that these are priority questions, and yet they've ranked them very differently. Before you left the hospital, did you get all the information you needed in order to know what symptoms or healthcare problems to look out for? And also, who do you contact if you have issues? This was ranked 3 times higher by patients than healthcare system stakeholders. The second question is, were the results of your diagnostic tests communicated to you and explained in a timely fashion and in a way you could easily understand? This one was ranked twice as high by patients than stakeholders. And then lastly, this question was ranked higher by healthcare organizations than patients. Were you informed how to escalate care with a rapid response team or how to seek a second opinion?
Yeah, and to share a little more about these three questions, before you left the hospital, did you get all the information you needed? That particular question does show up in HCAPS and the OECD Global Survey. However, it does not have who to contact, and that was very important to our patients. That not only do they know what symptoms to look for, but who do they contact? So this question is a bit nuanced compared to some of the other the questions that validate as tools. Regarding the results of your diagnostic tests communicated to you in a timely fashion that's easily understood. Now, we found a similar question related to the emergency department. I think it's called the LEAPed survey. And so we found similarities, but not specific to the hospital. And the were you informed how to escalate care? We did not find any measures in any country, quite frankly, that asked us directly, asked patients if we were informed how to escalate care or get a second opinion. So there's an opportunity to create some new measures.
So before we wrap up this segment that's looking at those shared priorities, go
Yep.
ahead, Armando, if you want to go to the next slide. There were 3 questions that were unique. So this first question is unique to patients, and they were very interested in being asked, were you given a list of pending test results when you were discharged from the hospital? I bet we can all relate, those of us who have been in the hospital or been with a loved one, about those pending test results. Unique to the healthcare professionals was, did you feel safe? Asking it directly, but more on a feeling safe. And that's a little different than some of the other safety questions that we heard earlier today. And then also, did you find errors in your medical records and were there means to correct those? Sue, if you want to make any comments about that before we move on to summarizing methodology 2.
We on the first question, the pending test results, we did not find any measures. And that, patients they want to be informed about pending test results or get a list of pending test results. We were unable to find any current measure anywhere in the world. And did you feel safe? That the Organization of Economic Cooperation and developed the OECD survey does have a similar question that we might be able to use some of their language. And did you find errors in your medical records and were there means to correct them? We did not find any similar kind of measures. Again, identifying opportunities to create some new measures.
Great. Next, so this is going to kind of wrap up the section of this particular presentation that's looking at part 1 and part 2 of Pivot's methodology over the last year. Go ahead, Armando, with the next slide, if you would, please. Where we went next is to take that list and segment it into 4 different groups. These are what we're referring to as the priority populations. And we are about to hear from the leaders of those 4 different groups, well, 3 of them, and then I'm going to present the last slide in that. What we want you to know here is that there were multiple rounds of this facilitation that included prep before a meeting this September, so a year later after our very first launch, and then the discussions, multiple iterations on one day of prioritization. There were the challenge for each of these groups: older adults, birthing people of color, people with disabilities, and then the really audacious task with the themed groups of going from 48 questions was to narrow it down to somewhere around 5. And you'll see how many questions they narrowed it down to. I think it's important also just to make sure that you understand that in reviewing this, they were incorporating edits that were suggested, but we didn't focus on the editing. So, for example, you're going to see multiple questions in one. Later on down the line, we're aware that that would have to be addressed in order to validate these tools. And also, they were asked to analyze the ratings based on the fact, were they clear? Was the question clear and understandable? And also, what was the importance of that question? So let me turn it over first to you, Rosie. Each one is going to take about 5 minutes, and I'll start with Rosie, who led the older adults population. And Armando, you can go ahead and switch that slide over to Rosie and then the questions that group prioritized. Hi, Rosie, go right ahead.
Sure. I'm Rosie Bartell, and I'm a patient partner. I have lived experience as an older adult. I am part of some of aging initiatives, especially with the aging initiative called IP4, and that group is a patient advisory group. And I see some of you on this call, so I'm glad you're here with us. As the older adults, we narrowed our 26 questions down to 8, but you will see that we are the problem child because we gave out more questions than we gave out questions, and then we prioritized them underneath the discharge, but they put it, we had 5 questions, but 3 of them came under one place. Okay, number 1 question: did you or your family member experience harm, physical, emotional, psychological, or financial harm from the care or treatment you received? If yes, what happened? How did it impact you and your family's health and well-being, physically, emotionally, psychologically, and financially? This was, as Sue said, this was a top question for everyone. Before you left the hospital, did you and your family member get all the information you needed in order to know what symptoms or health problems to look for and who to contact? During discharge, were you given help to set up your follow-up appointment care? Did you understand the discharge instructions? Were you clearly instructed about medicines before discharge? And that means every bit of your medicines, not just, not the medicines you came in and then the ones you got while you're there and the ones you did, but all of them. Were your family members or support persons included in your discussions, including at discharge, if you wanted them to be there? Were all of your conditions factored into your diagnosis and treatment plan? This was very important, especially when you have multiple chronic conditions. During your care, were you treated with dignity and respect? And by that we mean, did they honor what mattered to you? What are those things that were important to you to get back to? What were those things that were important to you to continue your life with dignity and respect? Hospitals don't treat you with dignity and respect many times, and you lose. The older you get, the more respect and dignity sometimes you lose in the hospital. I always say, if you've been in the hospital as an older adult and you have any kind of a disability, that you then have lost everything, every kind of dignity and respect. But if your hospitals keep asking what matters to you and what really is important to you, then you will leave there feeling that you were treated with dignity and respect. Pass it on.
Thank you, Rosie. Sue, did you have anything you wanted to add to that before we move on?
Yeah, I'm just gonna just that the last when Rosie talked about dignity and respect, this cut across several groups and Project Pivot and PFPS US is going to continue kind of further exploring this and further defining what dignity and respect means for especially the priority populations. Because it's a teachable question. So if it's more defined, we think that there'll be more learning.
Yeah, great. And Rosie, I just want to throw a shout out to you, who you got started very early on in conducting even, I think, a couple of focus groups before we met in September. And that was a very, very large group that you brought together to bring some really clear results with regard to what older adults are wanting to prioritize. Next up is Gabby Scott, who stepped in because we weren't, Gabby and Charity and their group did an amazing job of getting down into the details, which Gabby will share. And this group was originally led with Charity Watkins, who is also here on the call today. So Charity, a shout out to you as well. And so Gabby, what was your experience and what are the questions that your team, your group landed on with birthing mothers of color?
Awesome. Thank you so much, Vonda, for that wonderful introduction. As she stated, I am Gabby Scott. I represent a mother who has her own lived experience. I represent an advocate in this work. I have worked with North Carolina state senators on this specific work here that is focusing women of color with birthing experiences. I am also a social justice lead in the state of North Carolina with the National Council of Negro Women. So I am super excited to have been a part of this group and to have been in the space where we could all come together and create these outcomes. Next slide, please. Awesome. So I saw I've been watching the chat as the slide has been going on, and I saw that someone put in there, hey, there's multiple questions within a question. So I guess I have to jump on Rosie. We were also kind of a problem child because a lot of the questions were super compounded, and it was really hard to kind of narrow down what was like, oh my gosh, what do we stick with? What do we keep? What don't we keep? So we kind of we kind of rated like highest to lowest, and then some of them we pieced together and was like, hey, we just have to keep this. So our question number one was, did you feel that you were treated differently during your care? Due to, and then check all that apply: insurance status, insurance type, race, ethnicity, age, disability, gender, sexual orientation, weight, disease, socioeconomic status, employment status, education, marital status, family structure, number of previous children, identity of care partner, identity of my family, other factors specified in the open-ended question. That was a lot. And that's a lot to answer, and it is a lot to figure the best way how to approach this question, but it definitely lays the framework for how we can focus our efforts to figure out the best way to deal with that. And then we move to, if so, what happened? How did it impact your health and well-being physically, emotionally, psychologically, or financially? See outcome slides. Two, did you or a family member experience unexpected harm, physical, emotional, psychological, or financial, during or after giving birth? If so, what happened? How did it impact your family? And I believe I saw Cheryl Epps put a question in there about impact on family and finances. So this is definitely awesome and showing us that we are headed in the right direction. So thank you for that. Three, were your cultural or personal differences respected during your care? Some examples are referral to a culturally affirming doula, provider advocate, social worker, or lactation consultant. Four, did you feel your mental health needs and life stressors were understood and addressed before, during, and after delivery? Five, did the dismissal of your family members' concerns lead to a delayed diagnosis? And six, before you left the hospital, did you get all the information you needed in order to know what symptoms or health problems to look out for and who to contact? Example, connect to a mental health provider, primary care physician, and pediatrician. So again, I just want to point out that this is what we came together with. And we are so super excited about this, knowing that there's so much more work to be done. So just so again excited to have been a part of this group. Thank you.
Yeah. Thank you,
Thanks, Gabby.
Gabby.
Just to add real quickly, that we have looked at the questions that were created again de novo by the birthing people of color, and we map them to what's already out there that we might be able to use some language as we continue to refine these questions. And I have to thank the Family Health Initiative from New Jersey who did the maternal experience survey that they graciously shared with us, and we're right now looking at, how could we potentially collaborate them and use some of their questions. And also there are a couple of regarding being treated differently or the feeling of being treated differently. There are some validated survey tools out there that ask similar questions. One is the National Health Interview Survey, and the other is the Patient's Reported Experience of Discrimination in the U.S. Healthcare System. So we're going to carefully look at their language, see if we can recraft some of our questions, given those questions are already in validated tools.
Thank you, Sue. And next up, Lake Murray is going to roll through the questions that were prioritized by the People with Disabilities Priority Population Group, which was led by Carl Cooper, who is not able to be here today. But Lake has been with this process from the very early stages and was with us out in California very early on with some of that data collection. So I know you've got a lot of familiarity and involvement with this lake. Please go ahead and let us know what your experience was and what the questions were prioritized with this particular group, people with disabilities.
Yeah, thanks, Wanda. So I am Lake, and I'm the Health and Wellness Coordinator at the National Down Syndrome Society. The National Down Syndrome Society works to create a world where individuals with Down syndrome thrive through resources and support, community engagement, policy and advocacy, as well as research. On the health and wellness team, I do a lot of work to promote the well-being of individuals with Down syndrome and other disabilities as well. Being a part of this journey has been really great. I've learned a lot. It's also been really meaningful just to contribute the lived experiences of individuals with Down syndrome and other intellectual and developmental disabilities, as well as sharing my own perspective as someone with a disability. And it's been great to see that Project Pivot has been valuing these experiences. So with the process of prioritizing the
We need to change slides
yeah,
here.
can you change
We're on
slides?
birthing people of color. So Armando, if you
Oh,
could, if you go
Armando,
to the
yeah,
next slide.
sorry,
Yeah,
thank you.
there we
Perfect,
go.
thank you. I
There
wasn't
you
sure if I
go.
was frozen or if it was the screen. But good to know
I
I'm
was
not
thinking the
frozen.
same thing, like, sorry
Yeah.
about that,
Okay.
because
No,
mine's
no,
being
no
so
worries.
slow. Please go
Yeah.
ahead.
Okay. So the process of rating these questions was really interesting because people with disabilities is such a diverse group. We kept referring to this saying of, you've met one person with a disability, you've met one person with a disability. So how do we capture the range of diverse experiences, whether you have a physical disability, developmental disability, intellectual disability, and anything else that's captured by disability as well? But we did find some common ground and some common experiences that we felt that were best expressed or captured through these questions. So the first one is, did you or a family member experience a delayed, missed, or wrong diagnosis? If yes, what happened and how did it impact you or your family's health and well-being physically, emotionally, psychologically, or financially? The next question was, were you or your family members' concerns or your symptoms dismissed and attributed to your disability without further investigation or diagnostic testing? This question really stood out. I hear from so many families and my work with NDSS of often being dismissed, symptoms being dismissed because it's just Down syndrome, and a lot of the people in the disability group expressed that experience as well of symptoms being dismissed or attributed to their disability. The next question, during all stages of your care, were you offered the accommodations and accessible communication you needed to understand information and participate in decisions? This was another really important question to the group. Are healthcare professionals communicating in a way that people can understand, not only through plain language, but is ASL interpretation offered? Are AAC devices or other forms of communication respected? The next question, at any point during your care, did you experience bias or discrimination due to your personal characteristics? This question was interesting because the wording we felt, I think it might have been originally due to your disability, but a lot of people with disabilities don't identify as having a disability. So changing the wording to your personal characteristics further encompasses people with those experiences. And then number five, during your care, were you treated with dignity and respect? Again, this really tied back to hearing those experiences of people just feeling like because of their disability, healthcare professionals were not treating them with dignity and respect. And that was really important for that to be captured. Thank you to the Project Pivot team. This, like I said, has been a really great experience, and I've been happy to be a part of it.
Thank you, Lake. It's been great working with you. Sue, any comments on that before we continue
No, I
on?
think we should keep moving on. We have to make sure we have hear from
I
Divvy, who's going to
know.
really share about the healthcare systems and next steps. So we can go through this one pretty quickly.
Perfect. Yeah, we sure can. So you'll remember that there were 48 questions that we started with, and from those, there were 18 that, as Sue described, there are systems asking, prioritizing that. And so there were three from the themed group that rose up that were not part of that 18 list, and we wanted to make sure and prioritize those today. Did the dismissal of your or your family's members' concerns result in a delayed diagnosis? If yes, what happened? How did it impact your and your family's health and well-being physically, emotionally, psychologically, and financially? Number two, were you involved in decision making about your diagnosis and treatment plan? And third, did you receive information about your care in a way that was easy for you to understand, including accommodations for vision, language, and communication needs? I'm going to wrap up this segment and turn it over to Divi from Geisinger, who has been such an incredible champion and advocate for not looking, for taking this information about the what and the who and moving it to how. How would these be implemented? So, Divi, it's up to you now. And thank you all so very much for this incredible, incredible work with the healthcare systems work.
Thank you, Wanda. Thank you, Sue, and the PFPS team. And thank you all for joining us today. This is great, because all of this is you, and your presence here matters a lot. Um, the beauty of the hard work put in by PFPS, the research team, is that we have now prioritized and we know that what questions matter or what information matters. And now we have to sort of close the loop or join the dots and understand how we implement all of this. Because there won't be any point if health systems, hospitals, clinics don't really ask patients for these information points, because this is what's truly going to matter to patients and hopefully improve patient safety. So what we did is to give more meaning and strength to this brilliant work that you just saw that was done, over the last year. We invited a very diverse group of stakeholders that can help us understand how best to implement. And it's not rocket science. I think all of you understand when we try to implement something, we want to know what might be the biggest concerns, what might be the biggest barriers, and how to engage, whom to engage. So this 5W1H model, the big question here is how. If you can slide, please. And so this is our group. Like someone mentioned, there were generous hosts from the Hopkins Institute. We met. We had a number of different organizations, and I'll get to them in a second. But we gave this diverse group of experts and participants 4 questions to think about. How and when to ask these questions to patients in reality, in practicality. How feasible are these questions? How can EHRs and AI facilitate the collection, triage, analysis of all of this information? And how can we prioritize these prems and proms for further implementation. If you can change the slide, please. So here's just a representation. Take a few seconds to understand that all of these are already on the table. Coming to the table is a big deal, and I congratulate PFPS, and the team here to kind of bring these major organizations. Take a look at the healthcare organizations. There's Georgetown, there's Hopkins, there's Geisinger that I work at, Kaiser Permanente, Stanford, UCSF. And it's not just like big names. We had this lovely system from New Orleans, Bureaugat system, and the Dana-Farber Cancer Institute. Look at the patient safety organizations or patient experience organizations, Press Ganey, ECRI, and we had the EHR. Cerner is now owned by Oracle, so we had Oracle there. And associations, so Society for Hospital Medicine. There is a research network of hospitalists that is called Home Run, a hospital medicine reengineering network. They do a lot of research on diagnostic errors and whatnot. And then we had the University of Washington Medicine. They do a lot of work in disclosure, in communication and resolution programs. But then there are some very critical, and we had this Anesthesia Patient Safety Foundation. But there are two critical partners here. CMS was there on the table, in fact, represented by one of the chief medical officers. We had ARC, the part of the federal government championing patient safety and also involved in the HCAPS survey. We had the Leapfrog group. Most of you know Leapfrog group is like a patient watchdog group, but regarded as this safety grading authority in the healthcare organization. Just take a look at all these lovely, diverse stakeholders that were on the table. So what did we engage? How did we engage with them? Next slide, please. So they too took part in the prioritization, and I'll make this quick. So, they also ranked on top to try and assess the experience related to unexpected harm. Were the patients treated differently due to personal characteristics? Were your concerns dismissed? Did you know how to report a concern? Did you know how to escalate a concern? So you can see the theme. Next slide, please. So this group thought of, about 20 of us, we try to use our collective wisdom in the room, and 3 themes emerged. And this is, we thought, let's not wordsmith the question. Let's not think about the setting. Let's think about the theme that we want to make sure that healthcare organizations ask and seek information from patients. Harm, how to report and how to escalate, and sharing if you felt discriminated or dismissed emerged as the 3 top harms. And then we broke into 2 groups. We said, let's identify the barriers. So this may not be surprising to you, but the point here is that this was a collective wisdom of all these different diverse stakeholders. And they were very honest. They said, when we try to take these to health systems, among the top 3 challenges will be, what will the healthcare organizations do with this information? It's easy to say, hey, this is the question, ask the patients. But healthcare organizations have to think of how to operationalize all of this. What will they do with the data? Can we ask patients what financial harm you suffered, and then healthcare organizations are, what do I have got to do with financial harm? Because the thing that we are taking care of each other is not really, it's sort of theoretical in most places. There are legal concerns. Lawyers would be worried. Hey, why are you asking for different types of harm from patients when we cannot do anything about it? Or there might be operational challenges, cost, the resources, about the culture. Now, I don't mean to sound negative, but these were the barriers, and let's be practical. These are true barriers. And if we really want to make all our work successful and make sure the patient voice reaches the hospitals, we have to work on this. What were the national level policy challenges? Again, cost. There are existing tools that are very difficult to modify, and there's death by survey fatigue. What are the possible solutions? The whole group thought it is very important to engage CMS, insurance companies, and accreditation agencies, because hospitals listen to them. This emerged at the top. Second, let's do small pilots and generate some ROI and financial proof of concept that this is helpful and this would bring value to the health system, not just the moral right thing to do. And then you engage with malpractice companies and the legal lawyers so that they are less worried about it. Given the time, I think we'll move on. And next slide, please. And the most important thing is all these diverse stakeholders, they gave us a number of commitments. CMS actually encouraged us to engage, advocate, do the legwork, propose questions. They said the patient safety structural measures and QIUs are a very good avenue. Press Ganey is very actively engaged with us to include and test these questions in the surveys that they have at 40,000 organizations. ARC is willing to explore. IHI has invited PFPS to present on Project Pivot. They have a massive leadership alliance. So grateful to IHI and Press Ganey and the number of other organizations that said we are going to explore, socialize these concepts, take it to our senior executives, and let's think about how we advocate for these questions and how we implement them. I'll hand this back now to Sue. Once again, thank
Great.
you all. And all these organizations that are on the call today, please reach out to us. This is not possible without you.
Thank you, Divi. That was terrific. Let's go to the next slide and we'll close this. So what were the key learnings? What patients really want to report? They want to report the harm and the impact that it had on them. We simply are not collecting this information. Now, some of the questions that you heard today, it might be information that may not necessarily go into a survey, but it might go into some other reporting system. But this is what patients want our healthcare system to learn. We learned that harm from missed, wrong, and a delayed diagnosis and the events that led to the misdiagnosis was a very important issue throughout the entire project, with the concerns being dismissed as a key factor. When care was influenced by personal characteristics, you heard that through all of our priority populations, our patient groups, as well as our stakeholder group. That's very important. Some of the questions that are emerging are around AI. Was AI disclosed? Did patients have options to opt out of care when AI was used? Could they report harm from that was caused with the use of AI? Another emerging question was around delayed diagnoses was, did you experience delays due to the pre-authorization process? So we're seeing some current issues really bubbling up. Next slide, please. So our key opportunities going forward, we're going to continue to nurture, grow, and engage this community. It is the community who has made this project so successful. We want to take those questions. Again, the questions that we presented today are de novo and, straight from our patients. We're going to be mapping them to validate questions that are in validated tools. So to see how we can marry those together. We have the opportunity to develop some new harm measures that don't exist yet, especially that address the missed, wrong, and delayed diagnosis, disrespect, being dismissed, and biases in care. We want to explore possibly creating new patient-reported experience and outcome measures in populations or new settings, such as pediatrics, the ED, ambulatory, long-term care. We want to establish a patient-centered research agenda to improve safety, diagnoses, and bias in care based on the outcomes and experience that matter to patients. And finally, we want to actively explore how EHRs and AI can help facilitate the collection, triage, analysis, and reporting of patient-reported measures, both real-time, and we didn't really get to talk about this, both real-time and post-discharge. We want to continue exploring, and Debbie kind of touched on this. Yes, we've got some of these questions. We want to refine these questions. When do patients want to share this information and how do they want to report this? Is it, is it real time in the bedside? Absolutely. Is it later on when they're home? Absolutely. Do they want to report it via their cell phone, in paper, on the telephone? So we want to further dive into how and when the patients want to report. Next slide, please. So this is concluding our webinar. We want to thank all of our partners. We can't possibly go through all these names, but we want you to see the diverse group of patients and family members, patient and consumer organizations that joined us throughout this journey and hope that they will stay with us. Next slide, please. You can see our our stakeholder partners and collaborators from day one that have been collaborating with us. So a big, big thank you to all of you. And the last slide, we want to just make you aware that we are going to have a webinar on December 3rd that's called Advancing Patient and Diagnostic Safety in 2026. We have learned from Project Pivot, this is a key issue. And a lot of the other elements that we heard today that impact diagnostic safety. So put this on your calendars. You'll be getting Armando, correct me if I'm wrong, you're sending out an announcement tomorrow about the December 3rd webinar.
That is correct.
Great. Well, thank you all for hanging in there. This was a lot of information. We're excited about what we're learning about our patient community and our next steps. So please stay in touch we will stay in touch with you, and please stay in touch with us if you have any. Thank you, James. If you have any, reach out to us and we will continue this momentum. So with that, again, thank you all and have a great day.
Thanks, everyone.
Maybe the pivot speaker should stay on just for a second. Yeah, good. Well, congratulations, guys. I mean, I didn't get to read all the questions, but I mean, we finished it with just 2 minutes over, so it was nice and tight. You guys were direct and to the point. About we guessed about half of the people who registered came, and they did. I think we had like 148 registered, and we'll continue to reach out to those who did not make it to the event with the recording and as a group, as a community, let's talk about, what's next. And there are opportunities. Pivot is actively writing grants and reaching out to funders to keep this going. I'm confident that we will. And so just, a big round of applause to all you guys. Thank you. You're terrific.
Good
And I
job.
was proud that our community, it wasn't just one person speaking. We all contributed throughout the entire project. All of us on the screen right here and plus Lake, who's not with, we are all there from day one. So we got to see kind of this arc of progress.
Right.
Yeah, except for me sleeping on one slide. So, yeah.
That's okay.
Yeah, what happened there? Not enough espresso, Armando.
I know. I was waiting for Charity to send me one, but
Hey.
Yeah.
Huh?
Yeah.
Oh.
And all the people around, like you, Colonel Coffee, there to help support. I just always appreciate everyone just jumping in with what's needed in the moment. It's been such a great experience, and I very, very much look forward to continuing.
yeah.
Terrific.
Charity, you made it.
Yeah.
I was afraid
Yeah.
that
Yeah.
all the flight
I-
things were gonna.
I let Gabby, I'm like, Gabby, you go ahead and handle the presentation. I'll just field the questions in the chat. So
Yeah.
that's what I
Thank
took
you.
as
That
my
was
That's
great.
good. Thank you for doing that. Yeah.
No
I
problem.
Thank you.
appreciate you and Marty and a few other folks were in there right
Yeah.
at every step. That was great.
And Maria
Timmy,
is
thanks
still.
for bringing it home at the end. I mean, I think there are a lot of people eager to hear what you had to say.
Right.
Yeah, Maria still. I see you still on, and thank you. It's such a long friend.
Yeah, thank you, Maria.
Great
Thank
work,
you.
The
everyone.
support.
Thank you
Thank
very
you.
much. Thanks, everyone.
Yeah.
Thank
Have
you,
a great day,
everybody.
everybody. Bye for now.
Thank you, everybody.
Have a
Take
good day,
care.
everyone.